Good morning. I'm Glenn Coates. I'm the director of body MRI services, and you might ask, why is a body MRI subspecialist talking about the breast? That's because in the last 4 years, breast MRI has become an amazingly powerful tool that is used every day in a big way, and its indications are being expanded all the time. So I brought body MRI to Wake Radiology about 15 years ago. Body MRI was not done in Raleigh before I arrived. And in the last 5 years, we've opened a new service of breast MRI. And we're going to talk a lot about that because that's the one thing that many people don't know how to order and when to use. And there are going to be times when in your practice and with some of your patients, you're going to be the first line of people who think about a breast MRI. And I'm going to tell you how to think about it. So, but before I can even get to the end of the imaging spectrum, which is breast MRI, we have to start at the beginning. So I'm going to tell you everything you need to know about breast imaging. This is designed to be a basic outline of what we're going to talk about. We're going to talk about the breast imaging algorithm, mammography, ultrasound, molecular imaging, which is used every day, magnetic resonance thermography. I'm going to talk about the truth about imaging and radiation, and I'm going to tell you some concluding remarks that will hopefully summarize all of this in a way that you'll remember. We go to school to learn which imaging study to pick. How are you supposed to know what you're supposed to order? I hope that at the end of this, you're going to know exactly how to order what you want when it's a breast issue. So, I'm going to follow Einstein's rule. I'm going to make it as simple as possible, but not any simpler. I'm not going to use equations. I'm not going to use a whole lot of numbers. I really don't want anybody taking notes. What I'd rather you do is sit back, look right at me, and listen to everything I say. Because if you do, it's going to be broad concepts that I hope are logical in how you do this. You're also lucky that in the breast, unlike any other imaging in the body, the breast has a defined pathway of imaging, which we're going to talk about. The normal selection process for what modality, in other words, what kind of image, CT, MR, plain film, whatever, the normal selection process requires that you know what the strengths and weaknesses of that modality are. You're all closet radiologists, aren't you? You know all that, right? So how can you possibly make the modality choice that's right, which would lead to appropriate ordering, which would lead to meaningful results? How can you do that? It's a daunting task, and it's also why we are here today. We're trying to help you understand the basics so that you can do this for the types of modalities, CT especially, that you use on a daily basis. But I'm here to tell you some great news about breast imaging. You don't do that. You don't need to know any of that. Why? Because this was really difficult when it first started happening, especially with mammography. And so the BI-RADS system was developed. You see this every time you get a mammogram report. You may not know it, but you do. It's the Breast Imaging Reporting and Data System. Breast Imaging Reporting and Data System. It was designed by the people at the American College of Radiology to make a process easier for you to understand, make the imaging process of specifically the breast easier for you. It ranks abnormalities that are seen on mammography from grade 1 through 6. There's actually grade 0, which means incomplete, need more imaging. But the basic grades are 1 to 6. This allows radiologists to have consistency. Why? Because I describe a mass using different words, because I scored lower on the SAT test than that guy. I use different words than that person or that woman or whatever. I use different words. So when I come to my conclusion about what it is, how do you know that we're talking about the same thing? Well, what happened was this was rampant across the United States. In fact, it was rampant across the globe. Internationally, people could look at the same mammogram and come to different conclusions because they described the thing differently. So the American College of Radiology said, we need to standardize this. And so they did. It was intended to take the guesswork out of what the final conclusion was for all of you, so that you know what to do next. Doesn't matter how many different flowery words I use to describe it. The bottom line is, in my summary, I say BI-RADS something, and you know what to do with it. This is the chart. Remember, there is a BI-RADS 0, which means incomplete. Namely, I think this is a BI-RADS 0, we need to do this to figure out which one of these it is. The scoring is simple. 1 is normal. That means you go back to annual screening mammogram. Your patient does. You don't do any additional tests this year. You go to annual screening mammogram. Benign, same thing. 3 is probably benign, and it means that it's probably benign, namely it's not cancer, but we'd like to see it stay stable. We're not quite sure. We'd like to see it stay stable, so we'd like to have the patient come back in 6 months instead of a year. The normal is a year. We do a screening mammogram every year. We're going to talk about that. But this means let's see something at 6 months, just to make sure. But overwhelmingly, we feel that this thing that we're talking about in our report, whatever language we use, is probably benign. A 3. 4. There's 4A, B, and C. You don't care about that. A 4 means one thing. A 4 means you're likely to have to biopsy that. If it's a 4, you need to do something. Now, you're lucky because, again, we are required by this system to tell you exactly what to do next. So if we think it's a 4A and you don't have to biopsy it, we'll say that. If it's a 4B and we think there's just no way around it, you got to biopsy it, we'll tell you that. And if it's a 4C, you got to biopsy it. There's nobody anywhere in the United States that sits on a 4C. Okay, so again, 4 means it's suspicious for malignancy and we recommend biopsy. 3, you don't do anything necessarily. 4, you do something with a needle. 5, that means that on a mammogram it looks like a cancer and we're really concerned about it. Got to get it out. Okay, it's very simple. 6 is somebody who's already been biopsied and they're having additional imaging to work up that malignancy. And we're going to talk about that too. This system was designed to simplify the process of walking through the imaging workflow. Okay? It tells you what we think in an unambiguous way, a number, not words. It tells you by number what the next step is. Typically, it tells you what the timeline is to that next step as well. So it's designed to take it and make it easy. No other imaging does this. Abdominal, neuro, ortho, nothing. This is special to the breast. Okay, so this helps you hopefully makes it clear. The basic clinical process, you guys do this when you see your patients, is some test. Can be you putting your hands on them, or it can be an actual test. Leads to the detection of something. Then you do some more tests and you try to figure out what that thing is. You do some more tests and you try to figure out how much of that there is. And then that helps you design treatment if needed. So this is the basic clinical process for everything. You feel a bump on their skin. You do more tests to diagnose what that bump is. What that bump is tells you, well, I better know how much of that bump is all through the body. How much is all through the body tells you what your treatment's going to be. Okay, this is a basic algorithm that you all know. The imaging algorithm is exactly the same. We do a test, we detect, we do a test, we diagnose, we do a test, we stage, and from that information we design a treatment. But to do this, we have to define the broad categories of imaging tests or clinical tests. And I just want to review this. I'm sure you know this, but unless I do this, you won't understand the real importance and real meaning of the words screening mammogram as opposed to diagnostic mammogram. You need to know what the differences are. What's a screening test? A screening test is a test designed to find a disease before the patient has symptoms. Every one of us in here, we walk up, we have a test looking for a disease. It's actually a test that's designed to find a disease of low prevalence. Namely, you're asymptomatic, it's a rare disease, and it's a disease that's deadly, and we want to find it early because we think finding it early is curative. That's what breast cancer is. So, a screening test has to have certain components to meet the criteria of definition screening. It has to be simple to perform and interpret. It has to have a large capacity to test lots of people who don't have the disease. We have to look for it. It has to be available everywhere. It has to be pretty cheap. It has to do no harm. Okay, because these are people who walked into the test normal. You want them to walk out of the test, normal, not bleeding, not in pain. That's not a good screening test, okay? And the sensitivity to detection of a rare disease is the goal. In other words, we're trying to find this bugger before the patient has symptoms. That's what a screening test is. Classic screening test is screening mammography. Another classic screening test is chest x-ray in smokers. Okay, they're classic screening tests. This is one of them. This is how it's defined. So, how's that different from a diagnostic test? A diagnostic test is a test that is used to characterize something that we already know is there. Okay? Pretty basic. It has to have a target. That target can be a symptom. Nausea, pain. That target can be a sign. Mass, tenderness. That target can be a lesion. Something that we've seen on another imaging modality and we need to figure out what it is. Cost, availability, patient, pain, simplicity, they're not in the equation at all, unlike screening. Now, we've turned into the ultimate detective. We are trying to figure out what it is because identifying it as specifically as we can is what determines the next step. So this stage, a diagnostic test, is all about what is it. Screening was where is it, can we see it? This is what is it. This leads to the next step, which is staging. This is a test to determine the amount of disease in the body. Two types of staging tests, local regional, namely around the target lesion. Let's say it's a breast with a tumor in it. Local regional means the chest underneath it and the draining lymphatics that are right next to it where the cancer spreads. There's also distant staging studies, non-regional. That's for the detection of the spread of disease outside of the region. Okay, so let's be breast specific. You have tumor, so local regional staging is chest wall and axilla, maybe mediastinum. And then distant is whole body, looking for metastasis. It's all about how much disease is there. Why? Why do we need to know that? Because treatment is designed around how much disease is present. One treatment varies from another based upon the burden of disease in the body. It all begins in breast with one test. This is the test you order. It all begins with screening mammography. Now, screening, you all know what that means. This begins with you talking to a woman in your office who is currently asymptomatic and is seeing you for their annual physical. And you're ordering, because they're the right age, a screening mammogram. So let's talk about screening mammography and understand what its indications are. Every woman, 40 to 80, gets one every year. You can begin at 35 depending upon their risk. We're going to talk about that later. And if they have a really strong family history, you want to start at 30. And you definitely want to get a mammogram if the person you're talking to is planning on having a breast reduction or augmentation surgery. Why? Because you want to look at the tissue native before it gets rearranged by a surgeon. You want to have a baseline study to know what they look like that you can refer back to. No diagnosis is given on this screening study. It's a binary readout. It's either good or it's bad. Okay? Good means see you next year. BI-RADS 1, BI-RADS 2. Normal, benign. See you next year. Thumbs down is a different story. What you need to know is more about the strengths and weaknesses of this test to understand what thumbs down means. Mammography is an ideal screening test. It's cheap. It's available everywhere. It reduces mortality in women from 40 to 69. Now, that's an unbelievable statement. How many of you here think that there is another imaging test that claims that? Can anybody name a test that can claim that? No, the answer is no, because there is no other test that's had hundreds of thousands and millions of women tested and followed serially for years. You need that kind of population data to be able to decide whether or not a test has an effect on mortality. Not morbidity, mortality. Most of our tests have an effect on morbidity, how much the patient suffers. Mortality is a much longer endpoint, and there are no other imaging tests that have the claim to this fame. The test is an enormously powerful test that's supported by an even larger, enormous body of data. This is indisputable in all of the world's medicine and medical literature. It's very high resolution, which is what you need in a screening test to detect something bad early. It has very high sensitivity to these little white dots, which are calcium. These white dots have a different meaning than that white dot to a trained radiologist. Why is that important? Well, because in the evolution of cancer, the bad kind, which is called invasive ductal carcinoma, the kind that leaves the duct and invades the body, bad news. Those have little flecks of calcium in them. A lot of them do. Well, guess what? The pre-invasive kind, ductal carcinoma in situ, it hasn't spread out of the duct yet, also has calcium, and therefore if you see calcium with a test, guess what? You might be able to catch it before it's spread. Guess what? You might have a chance at saving somebody. Guess what? That's why mammography saves lives, because it has this enormous sensitivity to calcium. It's all about early detection. What are the weaknesses of mammography? Number one, it uses radiation, and we're going to talk about the truth in radiation later, but I want you to understand it does use radiation. It also uses compression, and that's a bad thing. And every woman in here is shaking her head, and the men are just like, duh. Okay, women, you know what I'm talking about, right? Oh, let me go back one. Okay, so it also has a problem with dense tissue. Let's talk about the tissue of the breast. There are 4 densities described in mammography. 4. This one, fatty replaced. It's predominantly black and gray in here, not white, like this muscle up here, white. This is predominantly black and gray, mostly fat. You get a little younger, or you are a little younger, or your genetics or your body habitus are different. You might have scattered fibroglandular elements. This is breast tissue is the white. So this is breast tissue in a sea of fat. Okay, so it's slightly denser. Dense is white. The muscle is very dense. The tissue is dense. Fat is not dense. Okay. The next step is heterogeneously dense. A little whiter, huh? And then you get the next step up, which is extremely dense. Okay, this is a lot of breast parenchyma in there, no fat. Why is that important? Why is the spectrum from fatty replaced to extremely dense important? Look at this. This is a cancer. This is a classic example of a cancer. This is a cancer in a fatty replaced breast. You all can see it, right? Heterogeneously dense. Extremely dense. Do you blame me for missing that? Okay, now, you'll note that we have a false negative rate. That's how often we miss a cancer in mammography. That looks really bad. But we miss that, we have a miss rate that high when it's a breast that is predominantly high density. And you'll see on our reports, the first sentence of a mammogram report should be the description of the density. Why? Because that sets the scene to you about how sensitive this study is going to be to the detection of a solid mass. If it's high density breast, it's the chance of 20% to miss something. If it's a low density breast, this goes way down to next to 0. Okay? It sets the scene about how accurate that mammogram is, and that's why we always say that first. And if it's a very high density breast, you'll hear us say the caveat of, in the setting of high density breast, 20% miss rate, blah, 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 blah. We want you to be really clear on the fact that this test is compromised by the density of the breast material. Now, false positive rate is much lower. We're very good at making sure that we're not wrong about what we're seeing. Why? Because what we see are calcium deposits that we're very good at detecting. And the calcium deposits have a specific pattern that's very, very, very good at indicating whether or not it's a cancer or not. It's rare that we take out calcifications that are truly not cancer. We do it at about 6% of the time. That's really good. That means we're not wrong about calcifications most of the time. So our false positive rate is very low. This is an ideal screening test situation. So what happens if your screening test is a thumbs down? That's a BI-RADS 0. That means inconclusive, we need more studies. Okay, so what that means is, and this is really important for you to understand, you need to tell your patient that a BI-RADS 0 is not bad news. Let me say that again. Your patient calls you and is really upset that she got a BI-RADS 0 from us. First thing you should do is say, a BI-RADS 0 recall does not mean that something bad is there. It means your radiologist is dedicated to making a good decision and wants to bring you back to make sure about what she or he is saying about what they see in your breast. It does not mean cancer. It does not mean biopsy. It does not mean disaster. It means we need to take a little more time than the routine test to make sure about what we're going to use as our BI-RADS categorization for this breast. Patient returns for additional mammographic views. Okay? No way around this. No way around this. Please do your part, understanding how this algorithm works, and make your patient know that it's necessary. Tell them to return. Tell them to endure. Tell them to trust that we're going to try to give them a good answer. It defines the BI-RADS categorization of the abnormality seen on screening mammogram. It takes the guessing out of what we're talking about, and it determines the next step. This, you must understand, the system is stepwise. Encourage your patients to believe in it. It's well tested and it works. So, what to remember about mammography? This is where if you're gonna, if your eyes have been closed, open them now, because these are the one-liners you should remember. You don't need to write them down. Annual screening mammography is mandatory if you're the right age. It's an enormously powerful test. The literature is indisputable worldwide. It is not to be missed. It has effect upon your patient's mortality, and there is nothing else in imaging that can say that. It is not to be missed. Societies worldwide endorse this. Now, despite what you may have heard in the lay press and from your patients, ultrasound and MRI are not a replacement for this. Even if your patient says, I can't stand having my breast squeezed, I'm not doing it. You have to do your best to talk them into it, because the data that supports a change in mortality is only there for mammography. It is not there for these tests. These are not a replacement, and every international society says so. It is not a replacement. Mammography goes on every year without fail. A recall for a diagnostic mammogram does not mean bad news. That's the take-home statement number 2. Reassure your patients that coming back in and letting us torture them again for another few views is absolutely the best next step. And to trust us, we're trying to do the right thing. Okay, so now what if the mammogram, diagnostic mammogram, is bad, inconclusive, we need more tests? What's the next step in the algorithm? That's diagnostic ultrasound. Okay? What are its strengths? It's very well tolerated. There's no compression. It's widely available. It's relatively inexpensive. It uses no radiation. Can't use it to replace a mammogram, which does use radiation. Be clear on that for your patients. But this doesn't happen to use radiation. Its primary uses are in deciding whether or not normal tissue is present, a cyst is present, or a solid mass is present. Now, I won't bore you with the details of radiology about what and how we know that, but those are the pictures that are representative of what its major primary use is. Normal, cyst, or solid. Sounds pretty crude, right? It's not normal, benign, malignant. It's normal, cyst, or solid. And it guides intervention. It's real time. It's like shining a flashlight right through the body. You can see things in real time, and you can watch the needle go right into the lesion. It is incredibly accurate for biopsying. It's the best way to biopsy something that you can see. Now, what are its weaknesses? Its quality is not regulated. Okay, now this is really important. This is really important. Mammography has got rules out of your mind regulating quality. Joe on the corner cannot provide you a mammogram. It has to be ACR accredited and all these rules, and you got to jump through hoops. It's a big deal to be able to do mammography. Ultrasound, anybody can buy the machine and start scanning you. Okay, so you may run into this guy. And you got to be really careful about where you get your ultrasound, because it's very operator dependent. Mammography is a standardized set of views. Boom, it's very reproducible. Ultrasound is the person, man or woman, has got to know where to put that probe and where to look and how long to look and what tools to use. I mean, it's very complicated stuff. In fact, there's a problem. When you're doing standardized views from one modality, mammogram, very standardized views, reproducible, and then you take that breast and you lay the person flat, and the breast is basically, forgive me for being blunt, it's jello, and it changes its shape completely, and then somebody goes and tries to find a needle in a haystack if they don't know what they're doing. If you're really high-end trained, you can find that mass that we talked about on the mammogram, because you can do 3D correlative spatial stuff in your head that you've been taught. But not everybody's been taught this. Okay, so there is a known, even for experts, a correlation problem between mammogram and ultrasound sometimes. Imagine, now you've got a mass that looks category 4. It needs to be biopsied. We send you to an ultrasound to guide the biopsy. And you go to somebody who's not trained and they say, normal tissue. You walk out. Uh-oh, you might have a breast cancer that was completely missed, namely sampling error. They didn't even pass a needle in there. You got given the green light when you shouldn't have. It requires expertise to do ultrasound. Don't fool around. The other thing you need to know is that ultrasound has low specificity. This is why I said the result is normal, cyst, solid. It's not normal, benign, malignant. That's specificity. We have terrible specificity in ultrasound. Terrible. It's like flipping a coin, whether or not it's a good thing or a bad thing if it's solid. But, like I told you, it allows you to do more things. What are the indications? It is an adjunct to mammography. Okay, when you see something on a mammogram that needs further delineation, you go to an ultrasound to decide if it's a cyst or solid. And that's why we have an order that says mammogram with ultrasound if necessary. And it tells you if the thing is a cyst or a solid thing. Cyst or solid. It has limited lesion specificity. We don't tell you if it's benign or malignant. But it allows us unequivocal guidance of a needle right into it to decide what it is. That's the specificity part of it right there. One more thing. You'll notice that I started with diagnostic ultrasound. Okay? Here's another take-home thing. Ultrasound is not a screening tool in the breast. It is a diagnostic tool in the breast. Let's talk about that for just a minute, because I'm sure you've heard about screening ultrasound. Let's talk about screening ultrasound in the breast. This was big news. Big news. WRAL, Dr. Mask, all over it. Thank you very much. Confused everybody. Now, lots of media attention. The problem is the literature said that breast ultrasound increased the specificity of mammography, but they had to be used together. Well, that small detail was lost in all the media coverage. What happened was the media seriously misinformed the public about what the power of ultrasound in the breast is as a screening tool. Again, you know the difference between screening and diagnostic tool. When you use ultrasound for a target to characterize it, it has great power. When you're just rolling it all over the whole breast looking for a needle in a haystack, you got big problems. Okay? That's not the way to use this study. But that little detail was left out, and we've been dealing with it ever since. You should have seen the editorials that came out after that published paper, because the paper was great, but the editorials were all about, oh man, are people going to misunderstand this? Holy cow, the way the paper's written, nobody's going to understand. And so it caused a lot of problems.
The problem is that you've never given us any criteria to select the sites that do ultrasound. So how do you guide somebody to have it correct?
Absolutely. And that's the fault of a lot of things. But the ACR is now beginning to accredit ultrasound facilities and trying to get things into line with the same thing in mammography. Same strict rules are supposed to apply. So hopefully it's changing. Okay, so screening ultrasound at this time. This is what the editorial comments of the experts nationally were after that paper was published. At this time, sonographic screening of the breast for breast cancer should not be performed outside of clinically defined trials. What to remember about screening ultrasound is you don't ask for it. You don't order it. It doesn't exist as far as your patients are concerned. Now, if your patients are part of a big NIH study and they're being done by the people who are trained and it's part of the research stuff, okay, great. But your regular walkie-talkie off the street patient that you see every day is not going to get a screening ultrasound of the breast. Please don't ask for it. Please don't order it. We will try to argue you out of it because it does not have data to support it in general public hands. I'll ask you for indulgence to ask at the end. Just write it down and we'll do it. Okay? Ultrasound is a diagnostic tool in the breast. If you remember that, you're in great shape. So let's talk about the next type of imaging, which is molecular imaging. This is a fancy big word that's all over the literature now. It's actually called, locally, it's called BSGI, breast specific gamma imaging. Okay, it's also called a miraluma scan. Okay, now let's talk about it for a sec because it's got some interesting properties. Let's talk about its strengths. It has very high sensitivity. It can see very small breast cancers just like MRI can. Not as small as mammography, but it's very good. It has a very high negative predictive value. Do you all understand what a negative predictive value is? A negative predictive value is a test. When it comes back negative, that means there's nothing you have to worry about there. If it has a high negative predictive value, boy, you want that test to be negative. What it does not mean is that when it's positive, we all know what we're talking about. It just means that when it's negative, it's really good. Okay, really good. But it's not always negative. It's inexpensive. It's many times less expensive than MRI. And we're going to talk about cost, but it's many times less expensive than MRI, which is why it's gaining popularity, because it has a lot of the properties of MRI in its sensitivity and specificity and negative predictive value, but it's 5-fold less. Okay? And it uses light compression. So let's talk about the weaknesses. Here I've told you it's all this great stuff. Number one, it uses radiation. As a matter of fact, it uses considerably more radiation than a mammogram. Considerably more. It's 12 mammograms, the equivalent of 12 mammograms to the breast. It also has high radiation dose to the heart and other organs, but when it's used appropriately, the risk-benefit ratio is appropriate. Limited availability. That's the big kicker. There's only one facility in all of Raleigh that does it. One, because this is brand new stuff. And you have to depend on your radiologists who know that it's there and know that they're taught how to use it and when to recommend it to know how to do this test. This is a special test. They do it at UNC, they do it at Duke, and they do it in Raleigh, but the facilities are even more rare than MRI. And everybody talks about how MRI has no capacity and limited, availability. This is even more limited availability. One of the other problems is that it does use compression. Women don't like it. It's light compression, but try to tell a woman what light compression is. Women, you all know that we don't know what light compression is, right? So, shaking big head, yes. Okay, so even though I say it's light compression, you still want to smack me, okay? It uses some compression, and that's why I know to put that up there. Now, what are the indications for it? The indications for this are very similar to MRI. They're very similar to MRI. But it's in low-risk patients, whereas MRI is reserved for high-risk patients, and we'll talk about that later too. What are some of the scenarios? You have a palpable mass, but a negative ultrasound and negative mammogram. Patient's really upset about it. Something's wrong. Mammogram negative, ultrasound negative, unequivocally negative. There's not even a benign finding there. It's not BI-RADS 2, it's BI-RADS 1. Okay, we're saying, ain't nothing there. Well, the patient's really worried, and you got to do something. Patient is low risk. Insurance will not pay for an MRI. You're in a jam. What do you provide this patient to give them the sense of security that they don't have an occult breast cancer in there? You give them a BSGI because insurance will pay for it. For low-risk patients, it's a problem-solving tool, and it has the same negative predictive value as an MRI. So if it comes back negative, wow, that's like having an MRI at a discount for a low-risk patient. Dense mammograms. Again, dense mammograms are always a problem. That's one of the take-home things you know about mammography. We have a miss rate for solid lesions, 20% in a dense mammogram. If you got patient worried, clinically palpable abnormality, dense mammogram, everything's negative, BSGI if you want to close the door on it. Again, you're looking for a negative result. You're looking for a negative result. Severe fibrocystic breast disease is a big problem, and we'll talk about that later. So what to remember about BSGI? It is a problem-solving tool. It is the third level tier of investigation in the breast, but only in low-risk patients. The ones who don't meet MRI criteria. Because MRI is the end-all be-all. It's the answer. So if you can't get there for insurance because they're low risk, this is what you substitute. It has incredibly high negative predictive value, so you're looking for a negative result. If it's positive, we still have to go one more step. If it's negative, which it is in most low-risk patients, it's a great tool because it's relatively inexpensive and it gets your patient to stop worrying because it has like a 98% negative predictive value. So how do you estimate risk? Okay, so I've talked all about how you decide BSGI versus MRI based upon the patient's risk. Well, you got to know how to calculate your patient's risk to know whether or not insurance is going to pay for the MRI that you might be considering. And no, they're not going to pay for it, so BSGI is my choice. This is how you estimate risk. You go to the National Cancer Institute website. Just go NCI and hit Control Enter, and it'll take you to the NCI website. And in there, there's a breast cancer risk assessment tool. How more clear can that be? Just follow the links. Okay? You click on that, and you get a bunch of questions. And it's just a pull-down menu. You just pull down, and you answer 8 questions. Okay? The questions are pretty simple. You have a personal history of DCIS or LCIS, and then they ask you about the patient's age, menstrual history, birth history, family history. A few simple questions. This is something you should do right in front of your patient. It takes just 30 seconds, and the best source of the information is the patient, right there. And if you don't have the time to do it right next to them, hand them the website and tell them to do it at home and call you back. Because this is enormously powerful information and very helpful. Now, one problem, like all computer things, if you select that first one, yes, it says, warning, cannot validate statistics, just ignore it. Just plow right on through. Just ignore that stuff. It's a computer glitch. It's about the statistics. If you have a positive personal history of either one of these things, you're automatically high risk, okay? So don't worry about the rest of the calculator. The rest of the calculator is really designed for people who answer no to the first one, okay? So just tell them, if they get a big warning flag and it says that the information is not accurate, tell them just ignore it and keep right on going and hit that button at the bottom. Okay? Because when they hit that button, if it's greater than 20%, insurance pays for an annual MRI. Annual. Now, I wouldn't tell you to do an annual on everybody who's 20, 21, maybe every other year. But if you're above 20%, 95% of insurance payers will pay for an MRI, at least a baseline, and some of them are paying for it every year. There's a big thing that nobody said in the newspaper and nobody knows about. 3 years ago, they had all these strict criteria where they would deny MRIs left and right. Now, they're not denying much of them anymore because their power is so clear in the literature about how much it helps. Okay, so let's talk about MRI now. We've moved on to the next one. Its strengths: no radiation, none. Extremely sensitive. If you have a 3 millimeter invasive cancer, 3 millimeter, the literature shows that our sensitivity to detecting that 3 millimeter cancer is 97%. Wow, that's pretty impressive. It has an incredibly high negative predictive value. If it's stone cold normal, BI-RADS 1, that patient has no risk of dying of cancer for several years from this result. Doesn't mean they don't have pre-cancer, doesn't mean they won't develop cancer, but it means at the time of imaging, they don't have an invasive cancer and they are good to go for several years. This is why you don't need to have a breast MRI every year unless you're really high risk.
Are you saying in addition to mammography?
Yeah, really what we recommend is that you do a breast MRI and you alternate years with mammogram. You never stop the mammogram. If you have a breast MRI that same year, you get a screening mammogram, because the whole power of screening mammography is the serial data to look for subtle changes. You don't ever, 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 ever miss an annual screening mammogram, even if you have an MRI. And your patients will argue with you about it because they don't want to get compressed. I had a negative breast MRI. I ain't going back there. Well, no, you have to, because it's all about the power of the serial data. Okay? It is the most accurate staging method for known cancer because of its lesion conspicuity and 3D power, and I'm going to show you that in a minute. It uses no compression, which women love. Okay, now, it also provides quasi-real-time guidance for biopsy, even when the lesion is not visible by mammogram or ultrasound. If we see it in MRI, we can biopsy it in MRI most of the time, unless it's right up against the chest wall or right underneath the skin. So, what are the weaknesses of MRI? Well, number one, you got to have somebody who knows what they're doing. Okay, and that's a real problem, and that's part of why in the early results time for breast MRI, we had really bad results, and we had pie on our face, and it looked like it was never going to evolve into anything powerful because too many people started to flex their muscles about knowing how to read it, and they didn't. Now it's much different, and you got to go to places that have thousands under their belt before you're going to really start feeling comfortable about knowing that the result is accurate. We have 3 people in my practice who read it, and we tracked how many cases it took until we all read them the same. How many do you think it took before we read them all the same? It took 500 cases before we started to see convergence in our interpretation. I'd call it a 3, he'd call it a 4. 500 cases later, we both called it a 3. So you have to go places with expertise. You have to ask them how many they've done and how long they've been doing it to know that you're going to get an accurate result in MRI. Just ask them. Don't be afraid. Ask them. It has limited availability like all MRI does. It's very expensive. Thousands of dollars. Okay? It's not to be ordered lightly, and it's to be done appropriately. This is why we really care when they don't meet insurance criteria, and we will, likely I will call you. If you order one and you fill out my history sheet and I don't see that it's going to be covered, I'm going to be calling you. And I'm going to say, I'm happy to do it. Happy to do it. But the patient better have a fistful of cash because I think they're going to be denied. And we can talk about the alternatives, BSGI, other things, that can be done instead of the MRI in that scenario. Claustrophobia. You hear people all the time, I want an open bore MRI. There's no such thing as an open bore breast MRI. You have to have a donut. Doesn't matter if it's a big donut or a small donut, but you got to have a donut and you're going in the tunnel. Nobody does open breast MRI. Nobody. Certainly not here, and certainly not outside of investigation. So claustrophobia is something that you all will deal with your patients. Let me tell you how it works for all MRI. Ortho, neuro, breast, it doesn't matter. Body, my specialty, doesn't matter. If they're terrified, send them to us. Don't prescribe them anything. Let me say that again. Don't prescribe them anything. Send them to us. We are experts at this. We use Valium. And guess what? They want to stay. As a matter of fact, I have people come to the desk and say, I ain't doing it unless Dr. Coates is here. Because I'm good with Valium. They love me, okay? It works. I've never had a patient fail. Let me say that again. In 15 years of doing MRI, I have never not been able to get somebody in the magnet. Even screaming, crying, terrified, holding onto the door, can't get in. If the, 50 IV, 50. Now you know why they like me. Okay, I'm very bold with Valium. I'm very bold with Valium. We've never had a problem. We have the reversing agent there. It's very safe. Never had a problem. So if I can get an IV in them, they're going in the magnet. And they're going to have a great study. They come out beautiful. So please tell your patients, trust them over there. Trust them over there. They know what they're doing. We have a doctor on site who can give Valium. I stand this far from the patient for every MRI. Every MRI. So if they go in and they're good for a minute and then they freak out, I'm right there and I'm giving them Valium. Okay, so just beware, it works. Positioning can be difficult for some people with bad backs. They have to lie like this, breasts hanging pendulous inside of the coil for 30 minutes. The problem is you might have a patient who's a little larger than most, and they can get in the magnet for their spine, they can get in the magnet for their brain, they can get in the magnet for their knee. They can't get in the magnet for their breast. Why? Because the coil raises them halfway up higher to allow those breasts to hang down into the coil. So we lose half the diameter of the magnet when we do a breast MRI. So your patients who fit for other studies might not fit for this. Have them come to us, and we'll slide them in and test. And we'll call you back and tell you whether or not it's possible. We will not charge them a thing. We do not want them to show up and be told they can't have it. We'd rather test anytime, anybody, send them to us, and we'll see if they fit. It cannot be done in people who have aneurysm clips in their head of certain types, and they can't be done on anybody with a pacemaker. Those are general MRI rules. They apply to everybody. So, what are the MRI indications? Well, this paper came out in 2007 and rocked the world. So I'm going to tell you what they said. This is when it just went crazy in the media for MRI. Screening, high-risk patients. You go and you do that Gail model calculator on all of your patients, all your female patients. Why? Because you can't look at them and tell they're high risk. Do it on everybody. If you're a good primary care physician, you should be doing this on everybody according to this paper, which is a paper written by something like 12 national institutions combined data. If you're a BRCA 1 or 2 genome patient, BRCA is the breast cancer gene, version 1, version 2, extremely high risk for breast cancer, ovarian cancer, other kinds of cancer. If you're BRCA positive, it's the e-ticket to an MRI every year. And there are some people who say, there's some early data that say those patients should not have mammography. It's the only population of patients that might be radiosensitive enough to say, don't do that. But that data is still not clear yet. And if you're a first-degree relative of somebody who's got a BRCA, mom's got BRCA positive, I don't want to be tested, I don't want to know, they get an MRI. Okay? Dense mammographic pattern, well, you know what that means now, right? And a prior history of a biopsy that shows LCIS or ADH, atypical ductal hyperplasia. You have one of those and a dense mammogram, you're in. Insurance pays. Scar versus recurrence at a lumpectomy site. You've got a history of cancer. You've had a cancer lopped out, your breast is still there, you got radiation, and your breast is deformed. You've got a personal history of breast cancer. Guess what? Whatever caused that in that breast passed through the other one on the way there. In other words, whatever environmental or genetic thing caused breast cancer in one side, exposed the other side. You are, by definition, high risk, and you should get a breast MRI. Opposite side, when somebody gets a biopsy positive, obviously we're screening the other side because we do them at the same time, and I'm going to show you why. If you've got a, this is a new one that not many people know about. If you are a woman who had a history of lymphoma as a child or as an adolescent and you got mantle radiation to your chest, you're at high risk. You get breast MRI. And some rare syndromes that I can't pronounce because I didn't score very high on the SAT, so I won't go into that. Okay, here's an example. This one was biopsied. See the little dot in the center? We knew there was a cancer on one side. We had no idea at all. There was another big one on the other side. We see this about 10% of the time. Again, whatever exposed one breast to what it takes to step over the line and cause cancer, the other breast was right there and got it too. It's just a matter of time in some cases. High risk screening. We're talking about risk now, high risk. Here's the classic pattern. You think I must see a solid tumor in that? I'm not. Look at how dense that is. I showed you the proof why that's a 20% miss rate for a non-calcified cancer. There's calcium, I can see it just fine. That's all benign calcium. Even that vascular calcium is benign. But the malignant type calcifications aren't there, but that doesn't mean there isn't a cancer in there that's not calcified, so I might miss it. And she's looking at it going, looks exactly the same on both sides, right? There's the CC view, classic standardized views, nothing. Let's look at that one breast. Here's the MRI. Okay, now, MRI is all about enhancement, and I can tell you that women who lactate and women who are young can have enhancement that's just incredible. Okay, now if I do one breast, I don't know what that is. Thankfully, God gave you two. And the national standard is we do them both. Don't ask for one, not for a discount. The national standard is two. Why? Uh-oh. There's a big difference between those two breasts, but the mammogram is the same. There's a 10-centimeter tumor in there with metastatic disease. Completely gone, not there on mammogram, completely not there on ultrasound, completely not there on exam. Completely replaced breast. Okay? This is why we always image two. The only misses we've had in our 5-year history, 3,000 breasts, is when the other breast was already gone. We didn't have an internal control. There was unusual enhancement. We didn't know. We're going to say it's probably benign. Patient pushed a biopsy anyway because we called it a 3. She said, I don't care, I want to know. And it was positive. So we've only had about 3 or 4 misses in all those years, and they were always, every time, in a situation where I didn't have a control. Okay? So you always do the other breast at the same time. National standard is bilateral. Scar versus recurrence. This person had a cancer right there. This is a typical appearance of a mammogram after radiation therapy and excision of a cancer, a lumpectomy. This is a lumpectomy, okay? Conservative breast treatment. This is what a cancer looks like. It's also what a scar looks like. And the scars get worse over years as the XRT matures, the radiation therapy and treatment matures, and so it can be a real problem. And guess what? Before breast MRI, every single one of these women went to another biopsy. Oh my gosh, we carved out more. Oh my gosh, even more scarring. Oh my gosh, the mammogram becomes useless. Now, we don't do this. This is where MRI shines. Here's the MRI showing the scar, T1, T2, looks just like a cancer there, but it does not color map, it does not enhance. Namely, this breast is completely negative. No biopsy, negative predictive value published at 99%. This is a BI-RADS 2, no biopsy. We don't make it worse. Patient is good to go. Amazing, powerful tool in the right setting. You have a patient who's a lumpectomy patient, get a breast MRI if you have any questions about their mammogram. So now we're going to talk about we talked about screening breast MRI, now we're going to talk about staging breast MRI. What's a staging test? How much is in the body? Why? Because that determines what kind of therapy, right? So, headline news again. This is, again, everybody lit up about MRI. New England Journal, big journal again, lots of people. State of the art, breast MRI is extremely helpful. Let me be really clear, because they were. State of the art. That includes not only equipment, but expertise, the person reading it. Be very careful. 10% of women with breast cancer have a second silent cancer either in that same breast or in the other one. Amazing. We missed those in the past. MRI is by far the most accurate imaging method to stage breast cancer. However, quality varies significantly nationwide. This was the first time I had ever seen in our literature, in our peer-reviewed journals, people talking about quality like this. They were warning people. It was a big red flag saying, guess what? Lots of people do breast MRI, but you shouldn't be ordering it from them, without actually saying it. So the statistics, if you follow this early statistic of breast MRIs, we were terrible.
So you're saying the study also made a comparison of different centers?
It sure did. It sure did. And it found that the results were really bad. They said, they actually went farther. They said, get your breast MRI at an academic institution only. That offended me. But I know half the people who were the authors of that paper, and boy, I was calling them that day. And Connie, who is the lead author, is my residency mate. She knows me really well. And she picked up the phone and she goes, hey, Glenn, are you mad at me? It's the first thing she said. She goes, of course I wasn't talking about you. Gee, well, write another paper and tell them that, okay? You know. So buyer beware. There are people who can do academic quality imaging that are not in academic institutions. Just go look for them. I'm not naming names. Go look for them. Now, a regional author who was one of the people in that paper came up and had editorial comments in our papers here regionally. This is Etta Pisano. Very, 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 very good mammographer over at UNC. Now she does nothing but research all the time. And she came out right after this was published and says, you don't want to find out a year or two later that there's a second cancer in the same breast or the other breast. You might as well design the treatment to be effective the first time. Why? Accurately staging determines the treatment. The right treatment can cure the patient. So you want to stage them the right way the first time. And she said, if I can get, there we go, 60% of the occult cancers detected in this study were invasive, suggesting that if we had not found them, they would have become clinically significant. She said because of these results at UNC, they were going to alter their screening protocols to begin performing MRIs on all patients who have had a biopsy that's positive. Wow! I don't think you can appreciate what that means. That's hundreds of thousands of patients in the United States just got their whole workup changed. Okay, it's a big deal for somebody to say this. So stage one, screen the other. Every time, do both. Don't ask for one. Classical indications changed that day. Okay, let me say that again. The classical indications changed that day because of this paper. Some women with biopsy-proven cancer needed a breast MRI to get accurate local staging to design the appropriate therapy. As a result of that paper, the new guideline said, all women. That's a big leap, big leap. And I'll tell you, most surgeons, even in our region, don't know this, even though it was in one of the biggest medical journals there is. They don't do this on every one of them. So we push them a little. On all of our mammograms that are 4 or above, we add a canned statement that is a reiteration of that paper and the national guidelines. Should the biopsy of the reference lesion in this report prove to be cancerous, breast MRI should seriously be considered before surgical excision. Literature states that MRI is the most accurate and complete imaging method for local regional breast cancer staging. Please consult your radiologist. We're trying to do what the national literature says. Not everybody's aware of it. That's why we put that there. We took a little heat at first when we put this on there until we handed them paper and said, read the paper, and now nobody argues about this because it is the national standard.
And what about biopsy negative? If there's scar tissue there?
No, that's negative. That's negative. And if it's the biopsy is guided right into the scar and it's negative, it's negative. Now, most people are not going to be getting biopsy of a scar anymore. They're going to get a breast MRI because that's an indication for it. And that way you're screening the whole breast. So is it really valuable? That came out. Is it really valuable? Does it make a difference? Well, here's a paper from the surgical literature, original work, Impact of MRI, based upon these guideline changes. Here's what they said. Since we started doing MRIs on all these patients, 44% of our therapy was changed. In other words, a patient had cancer, they're getting ready to do something, surgery, chemo, radiation, the MRI changed their decision about it. Changed the therapy. Why is that good? Because the change in therapy was adapted to the fact that they probably had more disease than we knew about, and now we're going to stand a chance at curing them because we knew more. But seeing is believing. You know, I can say this to you all day long, but it doesn't help. As soon as I show you this, you're going to understand why. This is what MRI is. It's 3D. You can see right through the breast to the tumor. It has unbelievable detail. The voxels, the little imaging volume that I use for my studies is less than 1 millimeter in size. And there are millions of them in each breast. So I have resolution that's incredible. I can use this power of 3D imaging to strip away skin with the computer. I can use it to strip away blood vessels selectively, target the tumor, and volumetrically analyze it in 3D space. I can tell the surgeon that that's a 27 cc volume tumor. I can tell them where it is, how many there are, how close to the chest wall. I can stage this thing better than anything they've ever seen before. Here's an example of why it's important. This patient came to me after lumpectomy, okay? Doc says after the fact, oops, I forgot to get that breast MRI. Well, that's okay. We're going to screen her just to make sure, because I know I got it all. All the margins were negative on my biopsy. I got the tumor. It's all out. But let's go screen that other one. This order came through. Positive biopsy here. Screen the other one before we go and design therapy. That's a win. Good. Good. They thought of it. Okay? The only problem is, here's the contrast study. There's something there in that same breast. Let's see what its perfusion pattern is. Type 3, that's highly likely to be malignant. Oh! Okay, now where is that in relation to where they were operating? Uh-oh. Okay, now this is good because now we know that's there. The therapy changes. Now instead of doing lumpectomy, this patient has to have a mastectomy. Big change. Big change. Now, the only better way to have done this was to have needle biopsied the first one, then done the MRI. We would have found this, you would have had one operation. How much does it cost to do a lumpectomy, just to go in there and pull that out? How much does it cost? Yeah, $20,000 most of the time, $15,000 to $20,000. Now, this patient had one operation, $15,000 to $20,000. Had we done the MRI first, one operation to remove the whole breast. Now, it's a second operation to remove the whole breast. So $40,000 to $50,000, well, $40,000 worth of surgery, 20 of which could have been avoided had the MRI been done in a different point in the algorithm. That's all. So this is why it's powerful. I think my batteries are starting to go. Here we go. Look at this. Look at this. Is there any doubt that you could tell how much is in that breast? I mean, you don't have to be a radiologist to see this. I spin this around at surgical conference every Friday morning, and surgeons are like, oh, well, there's the answer. You know, they don't even, you know, it's a waste of my words. They can see what it is. They know what they're going to do with that. Okay, so it is amazingly powerful imaging data. This kind of stuff that you see right here, rolling around 3D space kind of stuff, this is not normal breast MRI. I got to tell you, this is all about that state-of-the-art stuff. This is all about going to the experts. I've spent an extra $200,000 on a computer that allows me to do this. I talked my bosses into buying it for me. And It makes a huge difference to be able to see the data in this way. Not everybody does this. Some people just, they scan regular breast and they give you a report, and there's none of this. There's none of this appreciation in 3D space and stuff. So again, order the breast MRI from the people who are your experts. Go find out how they do it and get the right one for your patient. Okay, fibrocystic breast disease. I said we would talk about this. This is an enormous problem. Fibrocystic breast disease is a very common problem. It's benign cysts in the breast that cycle with with menses and cycling, normal estrogen cycling, and they're incredibly painful, and they're masses, and your patients come in all upset. Okay, you get a mammogram, and it's just like no help. And we even have a term for this, the nightmare breast. Right? Because we know we're no good. We're like, hey, we're going to flip a coin. There it is. There's nothing wrong there. I mean, we're no good here. And you need to know we're no good here. Now, you go to the next step in the algorithm. You go slap an ultrasound machine on it. It's like cysts everywhere. Okay? Is that a cancer? Can't tell. It's useless. So this is a real problem. This has been a real problem for a long time. Okay? Mammogram doesn't do any good. Ultrasound doesn't do any good. What about breast MRI? Here's what all those cysts look like on a water-sensitive image. This is what all those bags of water are in the breast. This breast is full of cysts. Now I want to see if there's a cancer there. I do the next step in the breast MRI, and all of that confounding information disappears. Those breasts are completely negative. No cancer. Imagine the power of that. Fibrocystic breast disease does not matter to us. We see right through it. Negative, no biopsy, no nothing, move on. So what to remember about breast MRI? Oops, it's the most accurate imaging method in the breast. Okay? But it's expensive, it's not available, and when it is available, you have to go the extra step to find out if the people who are doing it know what they're doing and how many they've done. That's a pain. It's begging for regulation, is it not? Exactly. It's very tough. It's not fair, and it needs to change. And it's going to change. How do you decide if they need a breast MRI? Go fill out the Gail model form, and it will tell you. It's very straightforward. Okay? There are other circumstances. Call a radiologist, and we can talk to you about it if you're in between. So let's talk about thermography. We're almost done. Thermography is something that's promoted by a couple of places here in Raleigh as the next best thing to sliced bread for determining whether or not cancer is in a breast. This is what a cancer looks like. The premise, the theory of this is that breast cancers recruit blood vessels because they need food to grow. And when they do that, they recruit heat. And therefore, if you have a breast cancer, your breast will light up with a lot of heat where the cancer is. And that's what these pictures show you. This is a distribution of heat throughout the entire chest. There's this big, ugly, crab-like looking thing in there. That's a cancer. Bingo, it works. It's very good, right? Okay? Well, all you got to do is go online to the National Council on Radiation Protection and Measurement. This is a national society that talks all about imaging and radiation. This is the place to go to get your answers. And you go there and you look at report number 149 on mammography. And what it says is this: thermography is ineffective in indicating the presence of a non-palpable cancer, detecting no more than half of the preclinical malignancies that can be discovered with the use of mammography. Namely, it's like flipping a coin. They go on to say, currently there is insufficient evidence to justify its use for either risk prediction or as an indicator of breast cancer prognosis. So the thing to remember about thermography is that it's useless. End of discussion. And if you have a patient who says, I've heard about thermograms, and they bring you in an internet thing all about it, you look right at them with confidence and say it's useless. And we don't want you to do it. Okay? Because it's like flipping a coin. So let's talk about the internet, because I have patients walk in with information all the time, and I want to talk to you about the internet effect. It's sophisticated. The internet is a boon to all of us because it's just a wide open information. And it's very sophisticated information. Do any of you understand what the word etymology is? Do you know what etymology is? Etymology is the history of words. It is the origin of words in our language. Do you know what the origin of the word sophisticated is? It is from sophist. Do you know who the sophists were? The sophists, by dictionary definition, a sophism is a specious, that means false, argument for displaying ingenuity in reasoning, for deceiving someone. It is a false argument of any kind. Who were these people? Well, if you go back to the time of Plato, Plato is largely responsible for the modern view of the sophist as a greedy instructor who uses rhetorical sleight of hand and ambiguities of language in order to deceive or to support fallacious reasoning. In this view, the sophist is not concerned with truth, but instead seeks power or money. Do you know the difference? Do you know why this term came up? Let's go to another word, philosopher. Plato was a philosopher. A philosopher was defined in that day as someone who was educated and tried to educate but would accept no remuneration for it. A sophist was the same but would only do it if accepting remuneration for it. You had to pay them to get their opinion, whereas philosophers were philanthropists. They gave their opinion and education for free. That's where this came from. So let's go and look at the internet for a sec, because I get these handed to me all the time. Currently, right now on the internet is this site, the Blaylock Wellness Report. This guy looks really, really respectable, doesn't he? God, I'd send my mom to him. No, that guy's good. Well, he's got an MD too, from a real med school. He was a faculty member at some university somewhere. And he's a neurosurgeon. Great. Okay, now he's retired, and he's decided that he's going to have a website full of all kinds of special reports, like vaccines that can kill, and all kinds of other stuff, like surviving your hospital visit. These are pretty hot reading, let me tell you. And I had a patient walk in with this: mammograms cause breast cancer. This guy's a doctor. Doctor, you're about to do a mammogram on me? Wait a minute, this guy says they're no good. Well, he says right here on his site, most women depend on that yearly mammogram to warn them about possible breast cancer. Yet, Dr. Blaylock points out studies that mammogram actually cause breast cancer, increase your risk 1 to 3% a year. Well, you do the math. You do the math. At 1 to 3% per year, and you get 10 mammograms from 30 to 40 or 40 to 50, oh my gosh, he says your risk is now 10 to 30%. What's the cutoff for high risk? 20%. Oh my God, mammograms make you a high risk patient. This is utter nonsense. This is not an understanding of statistics. This is not understanding of exposure. This is not understanding of radiation. This is not understanding of the risk-benefit ratio of an imaging study. This guy's got no business putting this on the internet. But I have patients walk in. This is a reproducible effect with the Blaylock Wellness Report in their hand. This guy is a single factor out there that is really a problem. He's misportraying the information. Yes, the internet is sophisticated. He makes money off that website. It's very sophisticated. And there's no shame, even though you wear an MD behind your name. The people are out there like this. You have to be careful. You have to be the advocate for your patient. So let's talk about the truth and imaging radiation. I told you that some of these things that we talked about today are radiation-based and some are not. How do you argue with your patient? How do you convince your patient that what you're ordering, a radiation-based exam, is good for them? How can you mount that argument when they've got to read this stuff on the internet like this? It can be tough. Well, everything in life, everything is about risk and benefit. And in imaging, the risk is cancer induction by radiation versus the benefit of mortality reduction. In many cases, it's morbidity reduction. Somebody's sick, you want to get them out of the hospital, you need an imaging test to do it. It's usually CT, that's a lot of radiation. How do you justify it? It's because morbidity can be changed. You find a positive appendix. They get it out, they go home. That's morbidity change based upon risk-benefit of the radiation of the CT scan. But in mammography, it's about mortality reduction, which is that next step up that I told you is shared by no other imaging. So it's an even better defined risk-benefit ratio where the benefit far outweighs the risk of the radiation, far outweighs it. Radiation from mammography is very low dose. So I talked about 2 imaging studies that use radiation, mammography and BSGI. BSGI uses about 10 to 12 times the radiation of a mammogram, but we still use it. And it still has a better benefit to risk ratio than not doing something in certain circumstances. So it's justified in giving them that radiation dose. There are 2 modalities that we talked about that do not use radiation. Those are ultrasound and MRI. They don't use it. But again, I told you they are not a replacement for this, even though they have no radiation, because there is no statistical data at all, and there probably never will be, because of the enormity of the studies that would be required, to prove that these change mortality like a mammogram does. It's indisputable that the radiation from a mammogram is worth it because it changes mortality in lots of people. Now, like I said, there is this one population that's evolving in the literature, BRCA patients, where the radiosensitivity of their breast may one day say, don't do mammograms in them anymore, but that's a very special patient, and we're not there yet. So the breast imaging algorithm we talked about today, this is it, and this is how it works. It starts with you ordering a screening mammogram every year on all your female patients based upon their age. It can progress to a diagnostic mammogram. Encourage them to go to it and get squeezed again. It can go to a diagnostic ultrasound. You know that it does not go to a screening ultrasound, and you know why. And from there we can go to BSGI or MRI, and then sometimes when a BSGI is positive we go to an MRI to solve the problem. And we do it that way because this costs less than that, and this has many more strict entry criteria from insurance than that. And so sometimes we have to go that route, even though MRI would answer it right from the beginning. We have to go through those steps. BI-RADS is your guide. Follow the numbers. They should be very clear in all reports. If you don't have a BI-RADS number at the bottom of your mammogram report, you shouldn't be sending your patients to that facility, because it is a requirement that we put that on there, and lots of places don't. It is required that we do that. And so one of the biggest flags about the quality of your radiology group or vendor is whether or not they follow these guidelines and put that unambiguous final statement on the bottom and tell you what to do next, because it is law in radiology that we do that. Okay? So, concluding statements. We're almost done. Here we go. Big, broad brushstrokes review. For breast imaging, there is a codified workflow algorithm that you can follow. It's not like other imaging. There's no guesswork. Your radiologist determines the appropriate disposition of your patient by that number, which is unambiguous, or should be if you've got the right radiologist. Mammogram is still the workhorse and the entry point to the entire algorithm. Annual screening mammography should not be avoided. It should be encouraged, always with vigor. Don't let your patients talk you out of it, no matter what they bring you from the internet. All other imaging options flow from that point. That's it.